Hello everyone. Today we'll be going through a couple of gastroenterology and hepatology related approaches. We'll be covering vomiting, jaundice, as well as gastrointestinal bleeding. So with regard to vomiting, I'm sure that most of us know that vomiting can be a pretty non-specific symptom. While intuitively, when faced with a patient with vomiting, we think of gastrointestinal causes, typically upper gastrointestinal pathologies, such as structural causes, some form of obstruction, or other problems in the stomach or esophagus. And secondly, central nervous system causes such as raised intracranial pressure or vertiginous giddiness that can cause pronounced vomiting. It's important to remember that pathologies in many other systems, such as the hepatobiliary system, genitourinary system, such as infections or pain due to problems such as stone disease, can actually cause very pronounced nausea and vomiting. The third group would be systemic diseases, and for purposes of the PACES exam, it is important to remember conditions such as diabetic ketoacidosis and Addisonian's crisis as causes of vomiting. So it's also important to remember that vomiting can cause complications such as electrolyte disturbances and cause patients to be intravascularly depleted, resulting in hypotension or postural hypotension. The next approach is that of jaundice. So in medical school, we learn about prehepatic, hepatic, and posthepatic causes of jaundice. Prehepatic causes would typically be the hemolysis, a group of conditions, which we'll go through when we go through anemia. Strictly speaking, portal vein thrombosis happens before the liver, so that kind of counts as a prehepatic cause too. So when we talk about the hepatic group of conditions that cause jaundice, I use the mnemonic very mad cow, which stands for alcoholic hepatitis, V for viral hepatitis, M for metabolic conditions such as NASH, and Wilson's hemochromatosis and alpha-1 antitrypsin deficiency. A stands for autoimmune causes, so that would include autoimmune hepatitis, primary biliary cirrhosis, as well as primary sclerosing cholangitis that tends to be associated with inflammatory bowel disease. D stands for drugs, and C stands for cardiac. So I think for purposes of the PACES, especially station 5, it is important to consider Wilson's disease as well as hemochromatosis. If one is taking the exam in the UK and there is a suggestion of concomitant pulmonary disease, then alpha-1 antitrypsin deficiency is something to think about. Of note, Wilson's disease oftentimes comes alongside neurological complications, and hemochromatosis may have complications pertaining to iron deposition in other organs such as endocrinopathies or some non-specific symptoms such as arthralgias, joint pains, and so on. It's important to remember that there are also other causes of jaundice, so malignancies, infiltrative diseases, infections, and the list continues. So when we talk about the whole post-hepatic group, so malignancies are definitely at the top of the list, especially if it is painless jaundice. Stone disease is also another important consideration, and I think in a patient who has a cholangitic picture, especially in the MRCP PACES exam, it is important to not just stop at diagnosing cholangitis, but to evaluate as to whether there is an underlying cause that predisposes the patient to cholangitis. So for example, this could be a patient with ongoing chronic hemolytic disease with pigment stone formation predisposing to gallstone disease. So once again, black chiari alongside portal vein thrombosis are disorders to think about, especially if apart from jaundice, there are associated symptoms such as abdominal pain, ascites, and one should then look for hypercoagulable risk factor states. The last approach is that of gastrointestinal bleeding. So classically, we divide them into upper as well as lower gastrointestinal bleeding. But perhaps before that, I think it's important to firstly confirm that this is a true GI bleed rather than things like hemoptysis, for example, and also to ensure that there is no systemic bleeding that may then suggest a coagulopathy. So then when we break it down into upper BGIT and lower BGIT, we think of the upper causes in terms of whether it's varicose or whether it's non-varicose. And for varicose bleeding, it's important to then look at the underlying liver disease, or rather the underlying cause of portal hypertension. In terms of the non-varicose bleed, apart from GI malignancies, peptic ulcers are common in real life, but in the context of PACES, one may think of rarer conditions such as Zollinger-Ellison syndrome. In the context of MEN1, it's also important to take drug history to look for like NSAID use. Some of the syndromes that can be featured in the PACES exam would include hereditary hemorrhagic telangiectasia or Peutz-Jeghers syndrome that can sometimes present with a picture that is not clearly upper or lower gastrointestinal bleeding. So oftentimes they may come in with stools that can be fairly altered. So instead of having a clear-cut fresh PR bleeding or coffee ground hematemesis picture, it could be somewhere in between, because some of these conditions can cause small intestinal disease. For the lower BGIT group, it could be number one due to a massive upper gastrointestinal bleeding. Anorectal causes would include pathology such as hemorrhoids, fissures, and in terms of the colon itself, one can think of non-inflammatory disorders such as colorectal cancer, diverticular bleeds, and angiodysplasias, or inflammatory diseases such as inflammatory bowel disease, ischemic colitis, and infective colitis. And for ischemic colitis, it's important to look for risk factors for atrial fibrillation or other forms of vasculitis that can predispose to gut ischemia. And for infective colitis, apart from typical bacterial infections, HIV opportunistic infections affecting the gut are also important. Of note, risk factors or associations with colorectal cancer would include that of acromegaly, where there is both an increased risk of colon cancer as well as diverticular disease. So this would be differentials for BGIT in such a context, and FAP and HMPCC would be a familial colon cancer syndromes. So I think that's the end of this presentation. Thank you.